Okay, let's pick up from where we finished last time when we had a look of the first section of the chapter 1. And let's review the remaining big concepts that I want to talk about. We're going to talk about homeostasis and then the language of anatomy. And we have a fair amount to go through on both of those. So I think that that'll keep us busy for this lecture video. So when we're talking about homeostasis, we're talking about one of the most central concepts that we'll see in our study of anatomy and physiology. We will use homeostasis as kind of the framework to explain how many multiple other systems and processes work. So that's why it's important that we spend the time and get a good grasp of this concept at this time so we can then make our subsequent study much easier. So let's think of how we can define homeostasis. And there are many different definitions for homeostasis. I see sometimes students talking about equilibrium or remaining close to the set point or consistency. So whatever definition you prefer, you're more than welcome to do that. I think that from my perspective, really it comes to the maintaining consistent internal environment within the body. This is typically accomplished through nervous and endocrine systems working together, but many other systems also step in. So how does homeostasis work? And you'll see at different textbooks, different source materials, different kinds of explanations, sometimes very complex diagrams, sometimes more diagrams that look like these seesaws, but I think we can do better than that. So what we're going to do, since I'm a simple guy, we're going to keep it simple for the content when we're talking about homeostasis. We're looking at homeostasis through this 4-box model where I'm explaining it through just 4 different elements. And everything starts with the stimulus. So stimulus is something that's changing. There's many stimuli around us all the time. I'm going to just use one example for our purposes, but you could really think of a lot of these. We're going to look at, for example, your internal body temperature as an example of a stimulus. Stimulus is a recorded, so sensor, or if you wish to call it a receptor, is constantly screening what's happening with that stimulus. For our example, to build up on that, we would have thermoreceptors, both internal and external thermoreceptors throughout our body. Do notice, though, that the sensor itself is not really aware of the stimulus, the status of the stimulus. It simply detects and collects information on it. So really, to give meaning to the sensors or receptors information, that happens at the level of control center. In most cases, the control center is going to be our brain. So we have, for example, thermoreceptors passing messages about the temperature to the control center, where it's then given a meaning. So in other words, we're becoming aware of that stimulus, that internal body temperature. So the giving meaning to this stimulus at the level of control center happens really thanks to the set point. And set point, you can consider that if we had a line here, and this would be all the possible values that we could have for the stimulus. So in this case, for the temperature, we have a large range of temperatures that we might have in the body, for example. But within that range, there's a set point. The set point is a range of acceptable values that would be normal, for example, for body temperature in this example. If the stimulus that's then being sensed through the sensor or receptor and then gets compared to the set point within the control center, if it falls within this set point, everything is fine. If it falls outside that set point, though, then we must do something about. A good example, again, building on this thermoregulation, temperature regulation for us would be, we would see in hypothalamus thermoregulation center within the brain on humans. So if the stimulus fell outside the set point, so that range of acceptable potential values, we will recruit an effector. So effector could be anything that we use to respond to these changes. This could be a behavioral thing. So for example, if we're thinking of that temperature example, putting more layers on or curling up if it's too cold, or removing some layers, or leaving the hot room if it's too hot, for example. Or it could be a physiological response. Let's say if it's too hot, we might start to sweat with the intention of trying to address that rising internal body temperature. If it's too cold, we might start to shiver, trying to produce some heat as those muscles are actively working. So that's what we're really seeing here. Most of the time, we will try to stop the change from happening, stop the stimulus from changing. And this is what we're talking about when we're talking about negative feedback. So most body's physiological responses are going to be negative feedback. And there's only 3 times when the change happens and we want actually more of that change to happen. And this is when we would talk about positive feedback. So those 3 examples for positive feedback are childbirth. So when the baby has turned within the uterus and its head is pushing to the uterine wall lining, that causes stretch to the uterine wall lining, which is the stimulus that we sense. We process that and we're like, oh, the baby is coming out. And rather than stopping that from happening, now we start to push even harder with the uterus so that the baby comes out. So that would be an example of positive feedback where a change causes more change to happen. Another example of positive feedback, the second example that we're seeing, is going to be breastfeeding. So when the baby suckles that nipple, that causes the milk to rise to the surface, which will cause baby to suckle even more of that nipple. So we're again seeing that this stimulus, the change in the stimulus, promotes more change to happen in this positive feedback. And a third example of positive feedback that I can think of would be blood clotting or scab formation, which kind of promotes more of that to happen locally. So all other examples would be examples of negative feedback. These are examples of positive feedback. I also wanted to mention the difference between afferent and efferent pathways. So if we're looking at that stimulus and sensor or receptor passing the message to the control center, that would be an example of an afferent pathway. So information coming in to the control center, whereas efferent pathway would be when messages leave from control center to the effectors. So we're moving away from there to make a change. That would be efferent pathway. Seeing really as a disease is when the homeostasis is off balance, so to speak. So we're no longer maintaining that balance that we want to have. So this is really the kind of key messages, key points that I wanted to share as it comes to the homeostasis. And like I said, this is going to be an important concept for us. We'll build up pretty much most other explanations on this. So please, please, please make sure that you feel comfortable with these concepts. Let's move onwards and have a look at the second portion for this video. I want to talk a little bit about the language of anatomy and physiology, or language of medicine in large. And sometimes students might initially find this a little difficult. I think that the big reason for that is that it differs from our normal language. This is because we want to be very, very precise with the terminology that we use. We want to make sure that the terms, the expressions that we use always mean the same. And there's also some historical reasons for that. So as it comes to the language of medicine, we see that a lot of terminology originates from Greek and Latin terms. We might have made some of those terms sound more like the ear of English speakers, but a lot of them have their origins in these 2 languages. That's one of the reasons why I'm very, very grateful that I, as a child, had to study Latin. So it made the transition to medicine really, really easy. Also, we see a lot of terms that relate to names, medical conditions, especially that are named after a person who either first diagnosed or determined whether it's a disease or determined the structure, describe the structure, or it can be even sometimes after the patients. I think this is one of the times when we're seeing some ethical consideration, and ethics is a big interest of mine. A lot of the names that we use in the language of medicine, I often describe them to my students as the medical language, as the language of dead old white men. So rather than you spending your time memorizing a name of a dude who might have a nodus structure, we're trying to do a movement, that there is a movement in the field of trying to actually describe rather what the condition is, rather than a name of a seemingly irrelevant person. So we're trying to find a little bit more meaning there. So sometimes we end up seeing multiple names for the same thing for that reason. We see a lot of abbreviations and acronyms also in the field of medicine being used, and then we have some terminology that originates from the technological advances, for example, MRI, which we most think of immediately when we see that abbreviation, what it is, but it really stands for magnetic resonance imaging. I have a background, I've done a lot of MRI research and nuclear medicine. The word nuclear sometimes scares patients. They think of the kind of radioactivity, whereas we're really talking about nuclear level behavior, atomic level behavior of particles. So sometimes we also change language to make it more easy to process for people. Also, in terms of the language of medicine, you will end up seeing in your fields, if you haven't already seen, that we use a lot of shorthand, especially in medical notes. So some of those will become very familiar to you as we're working through those. I also want to, at this point, remind you that medical notes are a legal document, so it is a good idea to be kind of mindful also what you jot down. Patient charts do become a legal document, and we should not go changing things afterwards as if we would have written something different than what we did. So always a little bit of mindfulness there, and I have some good stories and examples to share. Now let's take this language of medicine and apply it directly to some of the topics that we'll be focusing on. And let's start with the anatomical position. So sometimes students are confused by this anatomical position and concept of anatomical position. Really, the reason why we want to consider human body in this position is that it gives us a standard reference. We can always assume that the patient is in this position regardless of how they actually are. Sometimes in forensic settings, I've seen unfortunately human remains that have been partially dislodged, or body parts are not still together, or they might be in weird positions, unnatural positions. So when we're doing descriptions, we always assume that the patient would be in this position. So that gives us a standard that we can kind of all know what we're talking about, regardless of the reality. So it provides us a consistency and ease of describing. If I had to describe what an anatomical position looks like, we're seeing here an individual who's standing erect, feet parallel to each other, and the arms hanging at the sides with the palms facing forward and the thumbs pointing away from the body. So I think that gives us a fairly good description of what's going on here. Also, I did want to talk a little bit about the body regions. These are often named based on bones, muscles, cavities, and so on. Really, once you learn the body regions, it will become rather easy for you. It's the hard work of getting to that stage. And I will be providing you also either at the classroom or in an online setting a good handout for reviewing some of the most important body regions. So I encourage you to spend some time on that as well. I wanted to also talk briefly about directional terms. Directional terms are used to communicate location of body structure in relation to other structures. So a couple of terms that we're going to start with: superior and inferior. Superior refers to when we're talking about something that's towards the head or upper part of the structure. So it's kind of, you could use it as an analog for something being above. Inferior instead is something that's below, so away from the head towards the lower part of the structure. So below, you can think of that you have supervisors who are superior to you in terms of the rank in an organization, and someone who might speak to another person very inferiorly, they're looking down, if that helps you to remember that. But obviously, we can have more complex terminology than just superior and inferior because of the whole back and forth. Some animals stand on 4 feet, humans 2 feet. So whether we're talking in humans, we can talk of kind of analog for superior. Also, the term cranial, cranial referring close to the skull, close to the space within the skull where the brain is housed, or cephalic would be another one. Another term that I see being used kind of interchangeably with the inferior would be caudal. Really coming from the terminology referring to towards the tail. We also have terms anterior and posterior. Anterior refers to something being towards or at the front of the body. So in front of, this would be my anterior side, and my posterior side would be towards the or at the back of the body, behind. We can also sometimes, again, because of different body positions between different species, we can see that we use as analogs between anterior, the ventral, and posterior, the dorsal. So those also do get used. A couple of other terms: medial and lateral. Medial refers to something that's towards or at the midline of the body or on the inner side of the structure. So here my nose would be the very medial structure of the face. Lateral means that it's further away from the midline or on the outer side of the structure. So that helps to communicate some of those relationships between structures. We do see also these terms giving us a rise for more complex descriptions: intermediate structures being between the two, not quite medial, not quite lateral, and so on. Let's talk about proximal and distal. Proximal refers to something being close to the origin or close to the attachment to the trunk, whereas distal would be further away from the origin or away from the attachment to the trunk. So shoulder is a very proximal part of the upper limb, whereas fingers would be very distal part of the upper limb. We see these terms being used in other contexts as well. For example, I've done a lot of research on cardiac blood vessels that run at the surface of the heart. So if we talk about proximal portion of a vessel, that's where the vessel has really started recently. Distal is further downstream from that starting portion. We can also discuss structures as being superficial or deep. Superficial structures towards or at the body surface, whereas deep structures are away from the surface, more internal structures. I added this. This is not really something that I think that you need to know at this level, but I think it's kind of a nice one also to show supine. When we're talking about something being supine, if we talk about whole body size, body scale, this is a person who's laying with facing up, the face facing upwards. Prone person facing down when laying down. But it doesn't have to be just the entire body. It could be also part of the body. So it could be just our palms. So now my palms would be in a supine position, or now they would be in prone position. I think of it as supine position as your hands are in a supine position when you're carrying a bowl of soup, if that helps you to remember that. Let's leave these terms, directional terms, and have a look of a little bit of the body planes and body sections. So sections cut along the imaginary lanes of the planes of the body. This could be the entire body or just an organ. There's really 3 main types that I want us to look at. Sagittal plane. divides our body into right and left, and we can have sagittal plane at various different levels. If we're talking about mid-sagittal or medial plane, we're really bang on in the middle. But the big thing there is that we're dividing body into right and left. The mid-sagittal and medial plane is equal left and right halves. Frontal plane divides, or coronal plane is the other term that we sometimes use, divides us into anterior and posterior side. One way how my students think of the coronal often, I think of if you're putting on a crown, where your hands go is where that plane would run. And finally, transverse or horizontal plane divides body into superior and inferior portion, so upper and lower portion. But not all body planes align with these. We can sometimes have planes like oblique planes that don't really fit into any of those, so cut in a different angle to that. I also wanted to talk a little bit about body cavities. Body cavities hold organs within them, and there's really two main ones that we're going to see. Towards the back of the body, the dorsal cavity, and towards the front of the body, the ventral cavities. And we can further subdivide these. Let's have a look at the dorsal cavity. We can divide it into cranial cavity, which really houses the brain within the skull, and spinal cavity, which houses the spinal cord within the vertebrae. Ventral cavities can be again further subdivided to the thoracic cavity, which is the portion above the diaphragm in the chest cavity. This is where we find things like heart, lungs, and other structures there. Rib cage surrounds the thoracic cavity. We also see abdominal pelvic cavity. This is below the diaphragm, and abdominal pelvic cavity can be divided into abdominal cavity, where we see stomach, liver, and other intestines, and then the pelvic cavity, which houses the reproductive organs, bladder, rectum, and so on. Within the thoracic cavity, you also have mediastinum. This is the central thoracic cavity where your heart and trachea are housed. And do notice that abdominal and pelvic cavities are not separated by a physical structure. So there's not going to be an actual boundary there if we're dissecting. We can further divide abdominal pelvic cavity into 4 quadrants. So let's have a look at those 4 quadrants of the abdominal pelvic cavity. So we're going to have our right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. I think that is a pretty good description. Then we can use those to define what organs we find in each of the quadrants. For example, liver is mainly within the right upper quadrant. Stomach, for example, on the left upper quadrant. We would see appendix at the right lower quadrant, and we could see last parts of the large intestines at the lower left quadrant. Abdominal pelvic cavity can be divided also into 9 regions. So this gives us a little bit more specific way of seeing what's going on there. And again, starting from the right upper corner, we would have our right hypochondriac region, followed by epigastric region, and on the left-hand side at the upper regions, a left hypochondriac region. The middle row, so to speak, starting from the left hypochondriac region, right lumbar region, and umbilical region in between. Then what else are we seeing? We're seeing left lumbar region, left iliac or inguinal region, hypogastric region, and then the right iliac or inguinal region. So we're seeing those different regions if we wish to look at those. I do want to point out at this point that we do have also other body cavities, such as oral, nasal, orbital, or middle ear cavities, but really the 2 main ones that we're focusing are dorsal to the back and ventral to the front. And that brings us to the end of what I wanted to cover here on this lecture video. That's going to wrap up our recordings for our first chapter of our course together. I'll see you at the next recording.